everybody. Welcome to COVID-19 virtual reality simulation. So today we're going to go over the abdominal exam. So the purpose of this is just to kind of go over what we're looking for in test outs. This is a currently evolving situation with the coronavirus, so please keep up to date on check your email every day as things change. So, but we know for right now on the 17th we're not going to have labs, so we're recording this video. I don't know about the next lab. So let's get started with the abdominal assessment. The abdominal assessment is a little bit different than the other assessments, and one of the main things we're looking for if you get this body system on your test outs is that you're first doing your inspection, then you're doing your auscultation, percussion, and then palpation. So it is out of order as compared to the other exams, where auscultation comes second, where normally it would come last. We do this because if you palpate and percuss, it can alter the sound of the bowels and also the percussion and palpation can alter the sound of the bowels. So let's get started. The first thing we're going to do is we're going to reveal the patient's abdomen. And we're going to be looking for the skin color. We're going to be looking for vascular markings. Distended abdomens, especially people with ascites, can really have prominent veins and arteries appearing on their abdomen due to all the extra fluid that's in their abdomen. Also, you can see vascular markings or striae, which isn't a vascular marking, but it's like stretch marks in people who have gain of weight or loss of weight over a short period of time, such as with pregnancy or simply going through puberty. Really dark striae can be a sign of Cushing's syndrome, especially located on the abdomen with a protuberant abdomen or located on the back. So it's something to be aware of as a soft sign of Cushing's syndrome. We're going to be looking at the contour of the abdomen. Of course, distended abdomen can mean that there's fluid or air collection in the abdomen from extensive gas, constipation, having ascites, of course, in the abdomen. We also want to make sure that we're looking for any bulges or masses such as hernias, and then if we do see something that looks to be like a hernia, we want to palpate it to make sure that it's easily reducible. Incarcerated hernias can take on a very hard, firm appearance and can be quite painful to touch. So anything you feel with a mass, you want to take note of whether it's painful, whether or not, what the size is, and what the consistency is of what it feels like. So next step we're going to do is we're going to listen to Alex's abdomen. We're going to listen first for bowel sounds, and we're going to do this with the diaphragm of the stethoscope. And we're going to listen in all four quadrants. And in order, if you have more than 15, I believe in 5 seconds, you have hyperactive bowels. You can't declare that somebody doesn't have bowel sounds until you listen for 15 minutes. Yes, that's a long time in each quadrant. So that's what we listen for in terms of bowel sounds. When we tell you to listen for vascular sounds, what we want you to listen for is the right and left renal artery, the right and left iliac artery, the aorta, and also the right and left femoral artery. So let me show you how to do that. Let's start first in the epigastric region. The epigastric region is in between the ribs, right in the midline, and we're going to flip our stethoscope over to the bell, and we're going to listen for bruits or bruits. So we listen to the aorta. Now we're going to move to the left renal artery and the right renal artery, the left iliac artery, the right iliac artery, and then finally femoral arteries. Okay. So that's the auscultation portion. Those are the sites that we expect you to look for. I'm going to go ahead, since I'm on Alex's right side, and start with the percussion of the liver. So the way we do this is we're going to have Alex put his hand above his head, and the typical liver span is anywhere from 6 centimeters to 12 centimeters. So we're going to start with percussion. We're going to start about the third intercostal space, so not too far from the nipple line, and we're going to percuss. So at first we should be hearing tympany or resonance, because that's a normal lung sound. as we move down, we're starting to feel dullness. So I'm going to mark a spot right there, and then I'm going to continue to percuss downward. I got a feel right there. Can you take a deep breath, Alex? Okay, so I'm making sure I'm still over the lung tissue. And I'm not torturing Alex, he's very ticklish. Okay. So we're getting there. So I would measure this span. So where it goes from tympany or resonance to dullness is the span of the liver. And I don't have a measuring tape right on hand, but I would want to measure that to make sure that it's no greater than about 12 centimeters. So that's how you percuss the spleen. That's how you percuss the liver on the right side. Sorry. So then we're going to move over to Alex's left side and do splenic percussion. So there's a spot called Castell's point. I'm going to go ahead, you can go ahead and put that arm down now, Alex, thank you, and put your arm up here. And what we do is I'm going to feel for his costal margin. He's a little ticklish, so I'm trying not to make him jump up too high. And what I'm going to do is I'm going to start about the nipple line, and I'm going to go right below where the splenic margin is, and I'm going to percuss. And I'm hearing nice resonance, tympany, nice. When I get to Alex's mid-axillary line, it's kind of hard to see, but if you can come over here, Sydney. The mid-axillary line, I'm still hearing tympany. This is Castell's point. Castell's point is the point where you would determine that the liver is enlarged. So if I'm hearing dullness here, it's a good sign that the spleen is enlarged. Because when a person is laying down, their spleen should be more back here. I don't know if you can see this. More back here versus right here in mid-axillary line. So if I'm hearing dullness here, that's a concern. I should be hearing tympany, but in which I am right now. And then I'm starting to feel dullness back there. So Alex has a normal spleen size. So just to review, mid-axillary line or above, if you are having dullness, that's a concern that the spleen may be enlarged. Since I'm on his left side, I'm going to go ahead and start with the splenic palpation. What you should actually do is gently inch up as the patient is breathing inward. So Alex, why don't you take a deep breath in?
All right.
There you go. Keep taking a deep breath in, deep breath in, deep breath in. And what you do is you kind of wait for the spleen to palpate your fingers. A normal spleen is not palpable, and I'm not feeling anything. But if it was enlarged, so here's where Alex's, you can't see it, but here's where Alex's ribs are. If I shouldn't be able to feel a spleen up here, at this point where his ribs are, I might be able to feel the tip of a spleen, but it should be no bigger than that. So if I had an enlarged spleen, I'm going to start on your right side and continuously palpate up. If that spleen is enlarged as he's taking a deep breath in, that enlarged spleen will actually bump against my finger. So you just want to gently creep up and ask the patient to inspire as you're gently creeping up. It is normal to not feel a spleen in really, really slender people. Sometimes, like in slender girls, you can just feel it at the end, at the edge of the costal margin. So that's how you palpate for the spleen. And then finally, we're going to palpate for the liver on the right side. So there's two different methods for doing this. I like to do the hooking technique, which is what I teach students to do. So I want you to take a deep breath in, Alex, and right along the margin of the intercostal margin, I'm going to hook my fingers and press down, and I'm not feeling the splenic margins. Sometimes when the liver is enlarged, or sometimes in slender people, not when it's enlarged, you can actually feel the tip of the liver. You can feel a part of the liver along the costal margin, but you shouldn't be feeling it out here. So I always like to determine where the rib cage is when I'm doing this hooking technique, and I don't feel his liver at all. So that is all good, but that's the hooking technique for palpating the margins of the liver. And he has a nice normal liver and spleen. So there's some additional tests for peritonitis that I'd like to go over. I always like to call these the appendicitis tests, but they can actually be for any kind of inflammation to the peritoneum. So the first one I like to do is I'm going to have Alex, I'm going to have you uncross your legs. The first one I like to do is I want you to try, even though I'm pushing down on your leg, I want you to try to push up. Can you do that? Okay, lift your leg up, even though I'm trying to push down. Does that cause any pain? Okay, so that's normal. And that is called this iliopsoas sign. I'm going to have Alex now bend his knee, and I'm going to externally rotate and internally rotate it. And he's not jumping off the table, he's not upset, so he has a negative obturator sign. So the external rotation and internal rotation of the hip is not causing him any abdominal pain. That is obturator sign. If he had a positive obturator sign, he would not be able to tolerate me doing that. And again, iliopsoas is when I ask Alex to push up. So go ahead and push up, Alex. And I'm pushing down. And that causes the muscles, some muscles internally to get irritated. And if the iliopsoas muscle is irritated, that movement will produce pain in the abdomen, indicating that there may be appendicitis or other cause of peritonitis. I like to do it on both sides since we can also be assessing for peritonitis. Go ahead and lift up. Okay. Excellent. So those are some of the main ones. There is Markle's sign. I don't know if I have it on the test out, but it's some good information to know. Markle's sign is also called the heel jar test. So sometimes if I have a patient who I suspect or we're concerned about trying to rule out appendicitis, I'll come up to them and I'll pop them on the heel. That in a person who's having appendicitis or having peritonitis cannot be tolerated. It's very painful. So heel jar tests. I pop them there, or I have them jump. The other thing you could do is have them step off the table and jump, and if that elicits pain, it's considered a positive Markle's sign. Some other signs to look for that you can look for is, of course, McBurney point tenderness. McBurney's point is you want to find the patient's iliac crest. Here's Alex's iliac crest. And I'm going to push down and let go. Did that cause any pain? He's pretending like it didn't. I might have just pushed down too hard. So that's any rebound tenderness on that would be a positive McBurney sign. You also, some patients when they have appendicitis, they complain of pain on the other side, so you can palpate the other side as well, the left side, and that would be Rosvig sign. So sometimes when people first complain of appendicitis, they have peri-umbilical pain that goes to the left side, and then it finally centralizes in the right iliac crest. So those are some of the main ones. Then there's also Murphy's sign and CVA tenderness that you want to look for. So when we're looking at the superficial abdominal reflexes, I can take a Q-tip and I'm just going to brush these in a diamond shape to Alex's abdomen. And you have to really look really closely, and you probably can't see it in this video, but it's causing him to have a little twitch in his belly button. So that is normal. That's the superficial abdominal reflexes. A lot of times people will do this with a reflex hammer. So drawing a diamond around the belly button is superficial abdominal reflexes. Alex, I'm going to have you sit up now. Something you should always check if you suspect somebody has pyelonephritis. I'm going to have you turn around and bring your legs on this side of the table, Alex. Bring your legs on this side of the table. Thank you. And sit up. Perfect. So come around this way, Sydney. So you want to go around the costal margins, and doing blunt percussion is basically determining if there's any infection up to the level of the kidneys. So anybody who has a bladder infection, UTI, you want to make sure that you're doing this blunt percussion to their abdomen. Somebody who has true pyelonephritis or an infection of the kidneys would not be able to tolerate that motion. So blunt percussion to the CVA, the costovertebral angle. And then, let me think, I think that's all. Oh, Murphy sign. Let's go ahead and have you lay back down. So when you have the patient lay down, this is a test. Murphy's sign is a sign of a hot gallbladder, so cholecystitis. So you would want to go on the right side of the patient, about the nipple line, and you want that patient to take a deep breath. Take a deep breath in, and then push it out. And if somebody has Murphy's sign, they're not going to be able to tolerate this level of palpation, deep palpation, to their gallbladder area. So that concludes all of the listen to me, all of the abdominal testing that I require for you to know on test outs. Thank you very much.